Good morning, everybody. I'm so sorry about the technical difficulties. Right in the middle of Lancet's introduction, my computer just started doing the automatic shutdown. But yes, my name is Julie. I'm the International Nutrition Advisor with Samaritan First, and I've been in this role for over almost 2 years now, and it's been a privilege to be able to serve in this way. I help advise on the different nutrition programs around the world. I do a lot of proposal review, help with implementation issues. I do field visits, help with assessments or evaluations, troubleshoot, attend different kinds of meetings with other NGOs working in the same field. So that's mostly what I do for my job. The purpose of today's presentation, Heather, sorry, do you mind switching to the second slide? Oh, thank you. The goal of today's talk was to give people who work in the field in developing countries an overview of some of the different nutrition issues you might come across on the field. And I'm Nutrition 101, for those of you who aren't American, sorry, that term is a little bit American-centric. It just means basic nutrition. And so I'm covering some basics that some of you might know, but others of you might not. So I just wanted to cover some things. There will be a time for questions and answers later if there's anything that needs to be clarified or you want to ask questions that are a little bit more advanced, if this is too basic for your level. Let's see. So the first, I'm trying to remember my slides. Basically, when a lot of different times when Samaritan's Purse is on the field, we originally start in a country responding to a disaster. So there's many different types of disasters where nutrition would be relevant. Well, in fact, nutrition is probably relevant to most disasters because anytime there's a disruption, it usually affects the population's food supply. Samaritan's Purse has responded in many different types of emergencies, including famine or humanitarian conflict or some kind of flood, tsunami, cyclone, earthquakes, and all of these disrupt a population's food supply. Some of these are quick onset emergencies, and it could affect the markets because of mass destruction to the infrastructure, or it could be a slow onset where there's low rainfall over a season, which affects the harvest, and slowly the population food supply starts diminishing. We saw that a lot in recent years. And sorry, I'm clicking on the link. Okay, so we saw that in recent years, just more of these slow onset emergencies. In northeast Kenya near the Dadaab border, that's an example of a slow onset emergency where Samaritan's Purse responded to nutrition emergencies in that area. There was actually warning that there would be a nutritional crisis for about a year before it actually got to the extreme level. A lot of these disasters we can prepare for, and others we can't. I mean, all of them can be prepared for in terms of developing the population's resilience, but some of these, there's a lot clearer warning signs before they actually happen. Sorry. Sorry, trying to log in. So what
Julie, would it help me if I describe the next slides to you?
Sure. Sorry, I'm trying to multitask and log in at the same time. That's why. Yeah. What does it say at the bottom of that slide?
Well, the next slide that she has on currently, it says definition of malnutrition.
Oh, okay. Great. So there's different types of the overall general term used is undernutrition, which encompasses malnutrition as well as overnutrition. So those of you working in the States, most of the nutrition issues you probably deal with have to do with overnutrition. But for our purposes, we're going to talk mostly about malnutrition. There are places we work where there are issues of overnutrition, such as Latin America, but for the most part, we deal with issues of malnutrition. And there's different types of malnutrition. There's acute malnutrition, there's chronic malnutrition, there's micronutrient deficiencies. So acute malnutrition is the type of malnutrition that's quick onset, and that's mostly what you would see in emergencies. And when you see the children with ribs showing or distended bellies, that's under the category of acute malnutrition. And usually comes on because of some kind of sickness, illness, or acute food deprivation. The chronic malnutrition results more in issues of stunting. So that's measured in their height. You can't always tell the first time you look at them, but when you do some nutritional measurements, you can tell that based on comparing them to children of their same age, you can tell that they're shorter than usual, and that's usually because of chronic nutritional deprivation. And micronutrient deficiency, that type of malnutrition, the most common ones in developing countries are vitamin A, iron, zinc, and iodine. So those are the ones we deal with mostly on the field in developing countries. Those are the most common ones, and also the ones that have the most developed protocols on how to conduct interventions to address those micronutrient deficiencies. Next slide. What does it say, Lance?
Stages of acute malnutrition.
Stages. Okay, so there's different stages. A lot of you might hear the word MAM or GAM or SAM thrown around when you're on the field. Those are the most common terms used. Sorry, I'm trying to click on the link. So the most common, those are the most common. So what GAM stands for is global acute malnutrition. What MAM stands for is moderate acute malnutrition. And what SAM stands for is severe acute malnutrition. A lot of these are measured by either using the MUAC, the mid-upper arm circumference measurement. Some of you might have seen it. It looks like a small measuring tape, and it's color-coded with red, yellow, and green. The red zone means that the child is in the severe acute malnutrition stage. The yellow zone means that the child is in moderate acute malnutrition, and the yellow means they're moderate, and the green means they're mild, or the green means they're in the safe zone. So acute malnutrition can be measured either by MUAC or weight for height. And weight for height, you do a weight measurement and a height measurement, and you use Z-scores, a measurement on a bell curve to see what zone they fall into and how far they are from, how far they veer off from children of the normal height in their height zone. If their weight veers off a lot, if they're categorized as under -3 Z-scores, they're severe acute malnourished. If they're between -2, -3 Z-scores, and they're moderate, and that's all we have to worry about. You don't deal with the ones who are mild. So the important thing to remember is that the ones in the red zone under SAM, if you hear the word SAM or severe malnutrition, those are the ones that have the higher rate of mortality. So they're the ones that need immediate intervention. The category of SAM with complications is the ones that are the most urgent, that need to be cared for. And many of you medical practitioners, this is where you will interface with these children, because the children with SAM with complications are the ones that are in stabilization centers. Okay. So stabilization centers are the inpatient facilities where the children get 24-hour care. Okay. Sorry, Lance, I can see the screen now. Can you go to the next slide, please?
Are you on now? It looks like you're on. You can't see the screen. Oh, you can't see the screen?
Yes, I am on. I can't seem to, I can't get the moderator. Oh, actually, I can move, sorry.
Yeah.
Oh, okay. Okay, so let's see. Okay, so stages. The pictures you see on your slides right now are pictures of children with acute malnutrition, and this type of wasting is called marasmus. If you see on the left side, the child has a distended belly, or the ribs are showing in the middle, or on the right picture you'll see the loose skin around the behind area and the thighs. This is common for children with marasmus, with severe acute malnutrition, or SAM, or acute malnutrition. All of these are used kind of synonymously. And a lot of these symptoms you'll see in the stabilization center or in a program working with SAM kids. The signs and symptoms of marasmus is that there can be severe weight deficiency and growth problems that can eventually, in the severe cases, result in growth retardation, behavioral problems. A lot of these children will have comorbidities such as diarrhea or different infections or illnesses. They'll have anorexia, especially in the severe cases. They won't have any appetite, won't be eating. They'll have high blood sugar, and their temperature will be really low. So these are all different things you'll measure right when the child comes to the facility. And the children who have kwashiorkor are ones that have edema, and a lot of times it'll start in their feet. If you see the picture on the right, it starts. There's different levels of edema, which is indicated by a 1+ sign, or 2+ signs, or 3+ signs, depending on the severity. 1+ sign means it's usually just in the feet, and as it goes to 2 pluses, it will extend into their legs and their limbs, like their arms. When it gets to 3+ signs, it'll get into their face, as you see in the bottom picture. And the grade 2, grade 3 edema are very severe, and they'll go straight to the inpatient stabilization center. Children with kwashiorkor, they have bilateral edema. If it's just on one side of their foot or one side of their body, that's not kwashiorkor. That could be a result of some other illness, but for the purposes of nutrition, you're always checking to see it's on both sides of their feet and their limbs. A lot of times they'll have eyebrow and nail alterations, or they'll have liver enlargement. You can't always tell just from checking weight for height, the weight for height index. You have to do a separate check all the time for edema, because their weight might be more because of the fluid retention, but so it won't reflect on the weight for height measurement. You have to do a thumb pressure test. A lot of times they'll have like a moon-shaped looking face. And children with kwashiorkor often have behavioral issues. They might seem more than if they just have simple marasmus. They might appear sad or fearful or closed onto themselves. And the hair may also be depigmented, a little bit orangey or brown. Their hair is really black, or it might be very brittle, easy to break. And a lot of times they'll have some kind of mucus atrophy in their oral pharynx area. the physicians or nurses will be able to check. So the most severe type of severe acute malnutrition is when they have symptoms of kwashiorkor and marasmus. So a lot of times what they call is marasmic kwashiorkor, where they'll have signs of wasting, like maybe their ribs will be showing, as well as the edema. So when they're at that level, that's when you know that they have the highest risk of mortality. So typically, I covered this a little bit earlier, but the ways of measuring severe acute malnutrition are through the NUAC or through different indexes like weight for height. There's the other test for measuring edema by you put your thumbs, both thumbs, one on each foot, and you press on the tops of their feet for 3 seconds. And you hold the pressure down for 3 seconds. When you let go of your thumb, if there's still an indentation that's kind of stuck there, then that means that they have bilateral pitting edema. So it has to be on both sides. There has to be a lasting indentation for at least a few seconds. And then if they have edema in that way, then you check to see the rest of it's extended into their upper thighs and their arms and into their face to see the degree of edema. There's different, there's also different indices for measuring underweight and stunting. Stunting is the chronic malnutrition we discussed earlier. Underweight is a measure that can be attributed to either stunting or wasting. So that's weight for age and height for age. If Samaritans does longer-term development programs as well in areas where there might not be immediate emergency, but just chronic undernutrition, and that's where we would use weight for age and height for age. There's different types of ways of measuring more large-scale kind of surveys or rapid assessments where we use these measures. If any of you have been on a DART, like a deployment to an emergency, and if you're in a role of helping the nutrition work going on, a lot of times what you'll be assigned to do is help with a rapid assessment. A rapid assessment, you might get 150 children or 250 or 350, depends on the resources, where you'll measure it's not quite a random sample, but as random as possible. You'll get a bunch of children under the age of 5, and you'll do a bunch of NUAC measurements on these children. So that's what a rapid assessment is. A lot of times you'll accompany that nutrition screening with some qualitative interviews, some focus groups, maybe some interviews with the village leaders or some women health workers to get a picture of maybe what if families are using coping mechanisms, if they're decreasing the number of meals or the quantity of meals, or if the markets have been disrupted, and you'll get you'll ask questions as to some of the why behind the what. So that's a lot of times what will happen in a DART for emergencies, to get a picture of the extent of the nutritional crisis and what types of interventions need to be done. After a rapid assessment in an emergency, a lot of times they'll conduct a multi-agency survey using a methodology called SMART. And SMART stands for Standardized Monitoring of Relief and Transitions. And this is a more extensive survey, often using 600 children or more. And they'll do it over, they'll use random sampling using a specific software to do this. And it'll be statistically significant results in the end to be able to say this population has this rate of global acute malnutrition. And based on that GAM rate, they'll be able to say the nutritional situation is severe or moderate or mild based on the GAM percentage. If you've heard GAM rate, a lot of times that term is thrown around in the field, and it's because there are certain thresholds. Like, for example, if the GAM rate is the GAM prevalence, the global acute malnutrition prevalence, is over 15% in an area. That's often the trigger point for when NGOs will start doing intense nutrition programs. Sometimes people use a threshold of a GAM rate of 10%, and when it goes beyond 10%, that's the trigger for when you start doing nutrition programs, or when donors start coming in to start fund nutrition programs. So that's how GAM rate is used, and this is how GAM rate is through SMART surveys. That's how GAM rate is determined. So just to give you an idea of a lot of the types of programs that Samaritan's Purse does in the area of acute malnutrition, if you see the chart in front of you, there's the severe acute malnutrition with medical complications. That's usually inpatient care facility, 24 hours care for children, usually if there are resources. And usually a child will be in this facility for an average of about 7 days. It depends on the severity of the nutritional crisis in the area. Afterwards, they'll be discharged when they can pass, for example, an appetite test, when their edema is being resolved, and when their illnesses or their comorbidities are being resolved. They'll still have SAM, severe acute malnutrition, but they won't have complications, and so therefore they can be discharged to an outpatient kind of program. After their SAM is resolved, they probably will go into the moderate acute malnutrition, the MAM stage. So that's where they go into supplementary feeding. And so there's a certain type of program that encompasses all of these different types of care, and it's called Community-Based Management of Acute Malnutrition. The acronym used for this is CMAM. So CMAM encompasses the Stabilization Center, which is abbreviated as SC, an outpatient therapeutic program, which is OTP, and a supplementary feeding program, which is SSP. So a lot of times on the field, you'll hear people refer to as SV or OTP or SSP. That's what these things mean, or CMAM. Nutrition has its own lingo. It's almost like its own language. So a lot of times people throw out these acronyms: CMAM, SV, OTP, SSP, and that's what it's referring to: the Stabilization Center for SAM with complications, the OTP for SAM without medical complications, and the SSP, supplementary feeding program for MAM cases, MAM children. And these programs are usually conducted in emergency situations. Some of you might have been deployed to South Sudan. South Sudan is running a lot of these types of CMAM programs. We're also, SP is also running these in Liberia. We're starting an SFP in Mozambique. Niger is running one of these. And Cambodia was running the modified SFP. Vietnam was running a modified SFP, OTP type of program. So a lot of our countries do CMAM types of programs. And so if you ever get a chance to be deployed with Samaritan's Purse, you'll probably come across either SP or OTP or SFP. The other types of programs that deal more with chronic malnutrition, we also work with these in Liberia, in Niger, in Kenya. Kenya also has emergency type. In fact, every even emergency program should have some component of education or behavior change prevention that goes alongside the rehabilitation treatment types of programs. So chronic malnutrition programs usually deal with the prevention side to try to prevent and change behaviors that lead to chronic malnutrition and stunting. You'll hear the term behavior change communication, BCC, a lot. And what this refers to are different types of programs to basically change embedded behaviors that lead to chronic malnutrition. A lot of times the models or structures used for behavior communication are community nutrition volunteers. You'll see networks of these local women based in their communities who will communicate certain messages out to their peers. A lot of times you also see mother support groups where women get together maybe every week or every 2 weeks, and groups of women ranging from 10 to 30 people, usually not as much as 30, but where they can talk through issues of maybe breastfeeding or good recipes or complementary feeding for their younger children. Those support one another, and there usually be some kind of new teaching every time the mothers meet together. You'll have nutrition promoters, which is a similar concept to community nutrition volunteers, but people who are basically in charge of communicating and promoting certain key messages. And you'll have interpersonal counseling. That could be one-on-one. Oftentimes there's a model called care groups where certain women are assigned to go to different women in their communities and counsel them one-on-one on nutrition issues. And if you're wondering what are they counseling these women on, some of the topics that are typically covered are exclusive breastfeeding, complementary feeding, which is proper feeding from age 6 months to 24 months, maternal nutrition for women, which includes like increasing the amount they intake during their pregnancy, and a lot of times they'll be combined with antenatal care, making sure they're getting their deworming and other health messages along with nutrition messages. Micronutrient supplementation, they'll teach them on what they should be getting, where they should be getting it. For example, iron and folic acid during pregnancy, or vitamin A supplementation for the children, zinc during diarrhea, or vitamin A every 6 months for the children, that type of thing. Other chronic malnutrition programs are home gardens to improve the dietary diversity intake, or PD Hearth, which is using positive deviance, women who have healthy children within the community and seeing what they're doing differently so they can teach it to their peers, and recipe demonstrations, media campaigns, that type of thing. Lancet, the journal, produced a series in 2008 called in the Maternal and Child Undernutrition journal, which outlined effective nutrition interventions, which, if rolled out at scale, could reduce nutrition-related mortality and disease by 25%. So the nutrition community has taken the essential nutrition actions, the ENA, and basically tried to invest a lot of resources, time, and money into rolling these at scale all over the globe. So there's a lot of movements and advocacy movements around the ENA at the moment. And what ENA focuses on is the first 1,000 days. And you might hear that that's a catchy phrase in the nutrition community these days. What it basically is, the first 1,000 days is the child's life from conception to 2 years of age. And this is a window of opportunity because beyond 2 years of age, a lot of times some of the effects of stunting are irreversible. In the first 1,000 days, children are the most vulnerable, and to conduct interventions, it's the most cost-effective to focus on the first 1,000 days. So many nutrition interventions aren't even going to up to 5 years of age anymore. They're going up to 2 years of age to focus on this key window period. And what the ENA is, I'm going to go through these quickly since I'm running out of time, but promotion of optimal nutrition for women, basically trying to improve their dietary diversity, their intake, the right amount, the kinds of food, deworming. A lot of these can range. Different NGOs define these optimal nutrition interventions differently, but there's a few evidence-based ones that are very common across the board. Second one is promotion of adequate iron and folic acid for women and children. So a lot of these will be done through supplementation programs, but also through teaching on improved improves dietary intake through home gardens or using the local food. The third one is promotion of adequate intake of iodine. In most countries we work in, there is a national program for the fortification of salt with iodine. So this is what is being promoted. The results of iodine deficiency are goiter and at its extreme cretinism, where it affects the mental and physical growth of children. The fourth one is the promotion of optimal breastfeeding during the first 6 months. So exclusive breastfeeding, no other liquids, no other food for the first 6 months. And it sounds so easy, but it's oftentimes there's less than 80%, less than 50%, some even less than 30% adherence in many countries of exclusive breastfeeding for the first 6 months. A lot of times this also needs to be stressed within the hospitals or the homes where the birth is taking place to start the children off in timely initiation of breastfeeding within the first hour. So the fifth one is promotion of optimal complementary feeding starting at 6 months with continued breastfeeding to 2 years of age. So ensuring that the children are getting enough food at each feeding, are being fed enough times during the day with the right types of diverse foods. Also, the sixth one is promotion of optimal nutritional care of sick and severely malnourished children, that there's increased feeding, that there's increased breastfeeding, increased feeding, and the proper medicine needed, and that the caregivers recognize the danger signs of when these children need to be referred to facilities. The seventh one is prevention of vitamin A deficiency in women and children, which is usually through supplementation every 6 months for children, as well as trying to get them to eat foods rich in vitamin A. So a lot of times, if you're a doctor or nurse, these messages can be integrated into health sector programs. You can integrate them into maternal health or prenatal care, into delivery and neonatal care, into postpartum care, into family planning, immunization visits, into well child visits, sick child visits, and also in nutrition programs when you might be doing an outpatient therapeutic program or even in the stabilization center or in an SFP. So there's many different critical contact points where these messages can be integrated in, and that's how it works in a lot of SP programs. Health and nutrition are closely integrated at the field level because so much of this is interrelated. A lot of nutrition programs, the messages will also have health messages integrated and vice versa. So there's different trends in nutrition. I'll skip this right now because I'm past my allotted time, but just kind of flew through that right now.
Julie, you can go back. We'll let you allot you several, since we're responsible for a lot of it. Just go back to the last slide, no problem.
Okay, sure. So there's different innovations and trends in nutrition right now. In behavior change, a lot of time the nutrition community is realizing that a lot of behavior can't be changed without also involving husbands and fathers in the messaging, and grandmothers as well. You can tell a woman to use her extra money to buy nutritious food all you want, but if it's the husband controlling the finances in the house, the woman won't be, even if she believes she should be doing that, she won't be able to do that. So a lot of programs right now are focusing on involving the men in the household. Some of them will conduct different meetings involving the men, or just address the men by themselves in areas where it might not be appropriate to have the women or men together, or in areas where the women won't speak up if the men are there. So a lot of program is focusing on this. There's innovations in M-Health, mobile phone technology. A lot of times we conducted a program in Honduras where for trying to encourage adolescent mothers to engage in exclusive breastfeeding, they would be sent SMS text messages to remind them and can consult with a nurse through the cell phone after they receive these messages if they needed to. So, and mHealth mobile health is also being used in one of our programs in Niger. We just submitted a proposal to use mobile phones to keep better track of logistics in our nutrition programs. There's an increasing trend to integrate nutrition and agriculture programs together. It's already being done, but it's in a more intentional effort to, for example, use home gardens in nutrition programs, or including nutrition messages, behavior change messages within agriculture programs. So, for example, if a family and in their farm they have increased output of certain crops, they're not feeding that to the children under 6 months to displace exclusive breastfeeding. So I'm on a task force right now working to create more tools for the field to integrate nutrition and agriculture. There's a lot of different advocacy movements, global ones as well as U.S.-centered ones. SUN is a scaling up nutrition movement that's trying to get governments on board with investing time, resources, political will into nutrition programs in developing countries. The 1,000 Days movement is one that's based in America that's trying to focus nutrition funding and effort into the first 1,000 days, as we discussed earlier. There's locally produced RUTF ready-to-use therapeutic food. So, if you've heard of Plumpy Nut, it's a peanut-based paste that's used in a lot of OTP, outpatient therapeutic program, for SAM children. So a lot of this has been traditionally imported from places like France or the U.S., but now there's a movement to produce this locally. Some of the patents for Plumpy Nut are being released on a little bit more openly, so you'll see some more locally produced versions of this peanut paste more and more. And these CMAM programs are being integrated more and more into the Ministry of Health. In the beginning, a lot of NGOs were running this on their own. They were running them and kind of in charge of everything from the logistics to the actual implementation of the program. More and more, the capacity of the Ministry of Health is being built up, and so NGOs are coming alongside the Ministry of Health to run these programs. And so you'll see a lot of stabilization centers being based in Ministry of Health hospitals or health centers or that type of thing, where the NGO's role might be to conduct on-the-job training or to help with M&E, monitoring evaluation or logistics. Basically a partnership to try to be able to help these programs become more sustainable. And in these cases, CMAM is called EMAM, which is Integrated Management of Acute Malnutrition. So in a lot of these countries, you'll hear EMAM instead of CMAM. So those are some of the more recent trends in nutrition. And now we could move on to some question and answer.
Julie, I have one.
Sure.
In the very beginning, you showed a picture, and you were differentiating between kwashiorkor and marasmus. And often we know that in the field, we don't see either or, but we see a combination thereof. But you were showing some pictures of a relatively exclusive marasmus, and the kid had an edematous abdomen. Would you say, is an edematous swollen abdomen like that, is that part of the syndrome, or the descriptive of marasmus, or is that more commonly seen in, kwashiorkor? Like in marasmus, do you see just a totally emaciated kid in pure marasmus, a totally emaciated kid with, a flat or scaphoid-shaped abdomen, or is it usually protuberant like that?
I think that a lot of times it would be protruding, or it could, or not, but that would fall under the category of marasmus. And if it's sometimes it's mixed, like you're saying, so they could have a distended belly and wasting, and their feet are swollen. So if it's just the distended belly, then it's under the category of marasmus, because they could have a distended belly without the feet swollen, that type of thing. So, so I guess, did that answer your question?
Yeah. Okay.
Like you could see the distended belly, but also you might not see it as well for the same cases.
Julie?
Yes.
This is Shelley. Along those same lines, from what Lance was asking, as I was telling you earlier, I just got back from Haiti in January, and there were infants that came in. Is there any way to put pictures up on this board? Do you all know?
Sure. Go back to the marasmus or kwashiorkor pictures.
Go back to the what did you say?
Oh, sorry. Are you asking me to put up the pictures of marasmus or kwashiorkor?
Yes, and I'm actually asking, is there any way I can put up a picture?
Oh, I don't know. I don't think so.
Okay. Then, so there was a child, an infant that came in that was a month and a half old and weighed 1.8 kilos. And she had low blood sugar, and you were speaking to these treatment centers, the stabilization centers, and we did end up putting an OG tube down this baby and starting feeding because we didn't know what else to do. Is there, does Samaritans First have a protocol for this? As far as you get the infant in, it's the first time that, you know, the child has been seen, and this is what we do while we're getting them off to the stabilization centers. And how do we know where these stabilization centers are? Because it was kind of a tricky process. We were in Cité Soleil, and figuring out where it was and what to do in the meantime was difficult.
So you're asking what to do before they can even get to the stabilization center?
Exactly. Thank you, Julie.
You know, I remember working with one of the health PMs about that. Maybe I can send some protocols over to the folks that can be displayed somewhere, because Samaritan's Purse uses the international protocols for the stabilization centers, and there's a checklist of things you could do to treat them if you were the stabilization center. So I guess you would do the things you would do as if you were a stabilization center before they can even get to the stabilization center. So for example, using the NG tube if they can't drink the, actually you guys probably don't have the supplies.
We actually used a catheter. There was a small child-size catheter that I put into this baby doing with an OG, and we started supplementation through a catheter instead of an OG tube. Do you know what I'm saying? Same concept, different tools, but it worked.
Okay. I wonder if also having something displayed on where the stabilization center is, you can immediately transport that child.
That would be great. And I will say that Jill was a wonderful resource at that time, but not knowing what to do with the child before sending to the stabilization center was interesting.
Okay. Usually what's done in a stabilization center right away is they're given after the they're given powdered milk, like called F75 or F100. And so if you don't have that, then I guess the best thing would be to transport them as soon as possible.
Okay. Thank you.
And,
no problem.
And just to add to that too, that is actually a big push here at Samaritan's Purse, Shelley, is that we're developing protocols for a number of medical interventions. So that should be forthcoming, and we're going to do a better job as an organization of making those available at our various field sites.
Okay. Well, I think Jill did a wonderful job improvising and leading the team as we were trying to help this child. So it's good to hear that you're putting the programs together. It's just I had questions when I left that have kind of been hanging over my head since then about what to do about that. Thank you for responding.
Julie, Pam has a question.
Pam Follett.
Yeah, I have a question about what the current recommendations are with regards to exclusive breastfeeding in the presence of HIV and how that's currently being addressed.
If the woman has access to ARVs, antiretrovirals, then most times, like the recommendation changed in the last few years. Now, if they have access to ARVs, they consider it pretty safe to do like regular access to ARVs. So ensuring that there's a steady supply, and most times they mixed feeding is what is of most concern. If you try to do exclusive breastfeeding and you're trying to do formula, that's even more chances of passing on the virus. So if they have access to ARVs, it's pretty safe to do exclusive breastfeeding. That's what
the mom's being treated, then she can breastfeed.
Yeah, if she has a regular steady supply of antiretrovirals. So that's the recommendation. The issue which like the WHO recommendations don't speak to is if they don't have access to ARVs. And then it's questions of is substitute feeding like affordable? Is it safe? Is it consistent? You know, for example, formula or you know, a wet nurse or something like that. So I guess there's a lot of issues, clean water, that type of thing. So then it's up to the judgment, I think, of the nurse or the doctor in discussion with the mother to kind of talk through the context-specific situations.
Okay.
This is Tom, and I know we're running short on time, but Julie, you brought up some issues this morning that we could spend the whole day on. One is the role of fathers or men in this situation, and recently, and in fact, in the 3 years that I've been here with Samaritans First, there's not at Samaritans First, but internationally, there's been a very strong push on focusing all health outreach on mothers and children. To the exclusion of fathers, and ignoring the fact that in the world that we deal in out there, the men have a great deal of sway. Sometimes and many times it's the wrong way, but you know, I think that we really need to improve and augment programs that are reaching out to involve fathers in responsible fathering and in responsible husbanding. But that gets into the behavior change area. Behavior change is, we know it can take up to 2 to 3 years to change behavior, and it takes consistent application of truths to bring that about. Places where we're seeing that the most effective are places in the world where Christianity is the strongest and the church is influential. The other thing is that we know that malnutrition contributes 36% to death in children under 5 years old, of other causes. It's a contributing cause. So that there's a child dies in this world, one child under 5 every 4 seconds. 30% of that could be reduced if we could get, if we can address the nutrition issue. And it contributes to death from malaria, death from, measles, death from ARIs, and from diarrheal disease too. And then the last one is the application of mHealth and how we do that. And I've been really following the mHealth arena because it's an area where, with the growing ability to communicate, especially in Africa, that the rate is growing phenomenally. There are people's access to cell phones and to cell phone technology. So I think that, coming out with a whole program in the area of using mHealth for a number of applications, particularly getting back to the other two that I just talked about, is very, very an area that needs to, exploring. The last one is on the mHealth. We must remember when we're dealing with mHealth that they have proven conclusively that one-way messaging is not effective. It doesn't change behavior at all. So communication has to be, mHealth has to become from the standpoint of communication, and that is we have to set up an iterative process where we say something, they ask questions, and we feed back and forth, and that way there's growth. If it's just us as the experts feeding information out on the phone, those people can find a lot of other phone uses, which means conversation with friends, to use their phones and ignore text messaging. Okay.
That's good to know. Thank you, Tom.
Anybody else before I draw it to a close here? Okay, Julie, I just want to thank you so much. That was a wonderful presentation. I apologize for our little technical difficulties there. We'll rectify those. I apologize as well. As we go forward, we'll fix that. But thank you. That was a great presentation.